Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club, Transitional B-cell cytokines predict renal allograft outcomes, is hosted by the AST community of transplant scientists. In a moment, I will turn the session over to our moderator, Dr. Olivia Martinez, to introduce our participants. But first, before we begin the main presentation, we have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This Journal Club is being recorded, and the archive will be available on the MyAST website within 2 to 3 business days after the session. Please note that your lines have all been muted so that only the presenters can be heard for the archive recording. If you have a question for our panelists during the Journal Club, we encourage you to participate using the Q&A section of your Zoom webinar panel. Questions submitted via chat may be missed during the main presentation. If there are questions we do not have time for, we will either answer them individually offline, or we will post the full question with the answer on the website following the Journal Club. Finally, when you log off at the conclusion of today's Journal Club, you will see a link to a short evaluation survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Olivia Martinez, to begin our presentation.
Thank you, Brian. And I also want to welcome everybody to this COTS hosted AJT Journal Club today. I'm Olivia Martinez from Stanford University, and I'll be co-moderating the Journal Club with Aman Bajwa, the University of Tennessee Health Science Center. We're really pleased to have with us today Dr. Aravind Cherukuri, who is assistant professor at of medicine at the University of Pittsburgh, along with Dr. David Rothstein, professor of surgery, medicine, and immunology at the University of Pittsburgh, to talk with us today about their recent publication in Science Translational Medicine, Transitional B-cell cytokines predict renal allograft outcomes. Dr. Cherukuri will present the paper, and Dr. Rothstein will be available to join us in the discussion for the Q&A session at the conclusion of the presentation. So as Brian said, I urge the audience to submit their questions during the presentation via the Q&A feature, and Dr. Bajwa will moderate the Q&A at the end of the presentation, and we'll hope to get to as many of those questions as we can. So with that, I'll turn it over to Dr. Cherukuri. Thank you.
Thanks, Dr. Martinez. Hi, everyone. Good morning, good afternoon, or good evening, depending on where you're situated. I would like to first start by thanking the AST and the COTS on behalf of our team for giving us the opportunity to present our manuscript titled Transitional B-cell cytokines predict renal allograft outcomes in today's Journal Club. I do not have any financial relationships to disclose. B cells can either augment or inhibit the immune response, likely due to the presence of either pro-inflammatory or regulatory B cells. However, there is no specific phenotype for either the pro-inflammatory B effector cells or the anti-inflammatory B regulatory cells. We have previously reported that human B lymphocyte subsets differ in their ability to secrete pro-inflammatory cytokines, for example, TNF-alpha, versus anti-inflammatory cytokines, for example, IL-10. The ratio of IL-10 to TNF-alpha expressing cells in each of these canonical subsets correlate with their in vitro regulatory activity. Importantly, of all the subsets examined, the transitional 1 B cells have the highest ratio of IL-10 to TNF-alpha expressing cells, and this ratio decreases with renal allograft rejection. I don't think I have to convince this audience that the rate of late renal allograft loss has not changed over the last couple of decades. And this has been felt due to the effects of ongoing inflammation, which is often subclinical. Therefore, once transplanted, there is a steady fall off of allograft function over time. The basic premise of our manuscript depends upon the notion that early identification of patients at high risk for immunological damage may allow for preemptive therapeutic intervention before damage occurs, leading to improved outcomes. Therefore, we asked a question: if early assessment of transitional B-cell, IL-10, and TNF-alpha could serve as a biomarker for subsequent acute renal allograft rejection and clinical course. Before I start the actual biomarker studies, let me get you through the UPMC biopsy program. at UPMC and the Sci Transplantation Institute, all patients are offered to undergo 2 protocol biopsies, one around the 3rd month post-transplantation and the second biopsy performed around 1 year time. Diagnosis of rejection made on the protocol biopsies is classified as subclinical acute rejection. In addition, patients also undergo 4-cause biopsies anyway during the first post-transplant year on a medical indication. And rejection diagnosed on a 4-cause biopsy is classified as acute rejection. Based on the timing of the biopsies were classified as early when performed between 0 to 4 post-transplant months, and biopsies done between 5th and the 12th post-transplant months were categorized as late biopsies. So of the 596 patients who were transplanted at UPMC between January 2013 and December 2015, 468 patients, that's almost 80%, had at least one biopsy done within the first post-transplant year. Of these patients, 330 patients had paid early and late biopsies, allowing us to examine the evolution of the rejection process within the first post-transplant year. Let me make a comment here. In this cohort, acute rejection was 97% T-cell rejection alone, 3% ABMR and mixed T-cell rejection, and none of our patients had pure antibody-mediated rejection. So here on, you will see the term T-cell rejection to refer to acute rejection in our cohort. So based on our assessment of the paired biopsies, we found that 25% of the patients had a diagnosis of rejection in the early post-transplant period between 0 and 4 months post-transplantation. Here, there was almost an equal distribution of clinical and subclinical rejection. Both clinical and subclinical rejection episodes were treated per protocol using a combination of using either steroids or depleting agents, biological agents, depending upon the grade of rejection. Importantly, despite conventional therapy, 44% of these patients continued to have either recurrent or recalcitrant rejection when the histology was re-examined between 5 and 12 months post-transplantation. Also, in this late period, most of the late recurrent rejection was supposed to be subclinical rejection diagnosed on a protocol biopsy. In those patients who did not have early rejection early on, that is 75% of our total population, a quarter of these patients almost have late rejection diagnosed between 5 and 12 months post-transplantation. Again, late rejection was dominantly subclinical, diagnosed on a protocol biopsy. So when we examine the relationship between the diagnosis of rejection in the first post-transplant year and 5-year death center graft survival, we found that early TCMR was associated with poor graft survival. So acute rejection is bad. Based on our assessment of the evolution of rejection in the first post-transplant year, we found that patients who have either de novo late rejection or recurrent or recalcitrant rejection have significantly worse outcomes, as you can see in this Kaplan-Meier curve, compared to those patients with no evidence of any rejection within the first post-transplant year. Again, importantly, patients who had early rejection that resolved, as you can see in the gray curve, have almost comparable clinical outcomes compared to those patients who have no acute rejection at all. So late acute rejection is bad. Early rejection that resolves is not so bad. Then when we examine the association between late rejection and clinical outcomes, we found that late rejection, whether either subclinical or clinical, is associated with significantly worse graft survival compared to those patients with no evidence of late rejection. So late acute rejection is bad, either clinical or subclinical, and especially clinical. Therefore, a non-invasive biomarker that can not only predict acute rejection, but also late acute rejection before it occurs would allow preemptive therapy aiming to prevent further damage and improve clinical outcomes in transplantation. Let me take you through the study flow of our study. So of the 596 patients who were transplanted between January 2013 and December 2015, 468 patients had at least one biopsy done in the first post-transplant year. Of these 468 patients, 244 patients consented to participate at the UPMC Sci Transplantation Institute biorepository, and the remaining 224 patients did not participate. So all the 244 patients who participated in the biorepository were included in our study. Of note, there were no significant baseline demographic or clinical characteristic differences between those patients who participated in our study versus those who did not participate. So of the 244 patients who participated in the biorepository, 158 patients who were transplanted between years 2013 and 2014 constituted the training set. And the remaining 82 patients who were transplanted in year 2015 constituted the internal validation cohort. Let me now explain to you what the biomarker is. To assess the biomarker, PBMCs were stimulated over CD40 ligand expressing monolayer cells along with CpG for 24 hours. CD19 positive B cells were further categorized based on the relative surface expression of CD24 and CD38 into transitional, naive, and memory B cells. The CD24 bright and CD38 bright transitional B cells can further be classified as previously described into T1 and T2 transitional B cells based on their relative expression of CD24 and CD38. After 24 hours of stimulation in a tissue culture plate, intracellular staining by flow cytometry was performed, and the IL-10 to TNF-alpha ratio within the B cells and the individual B cell subsets is calculated as a total IL-10 expressing cells, the ratio of total IL-10 expressing cells to the total TNF-alpha expressing cells, as you can see in this graphic. Of all the parameters examined, the T1B IL-10 to TNF-alpha ratio measured at 3 months has the best predicted probability for rejection and has been used to study as a biomarker for predicting rejection in clinical outcomes in our study. What are the study outcomes? So the biomarker assessment at 3 months has been correlated with, number one, any acute rejection diagnosed within the first post-transplant year, the diagnosis of de novo late rejection after the assessment of the biomarker, again within the first post-transplant year, the diagnosis of subclinical rejection diagnosed on the protocol biopsies done either at 3 months or at 1 year. The late clinical outcomes included, number one, death sensor graft survival, graft loss including death, and we also utilized a composite endpoint of graft loss and impending graft loss to be able to identify those grafts which are almost falling off and still haven't lost complete function. Impending graft loss is defined as EGFR less than 30 mils per minute plus delta EGFR from baseline to the point of final assessment of less than 30%. The first clinical outcome, any acute rejection within the first post-transplant year. In the training set, patients who developed rejection in the first post-transplant year had significantly lower IL-10 to TNF-alpha ratio compared to those patients who did not have rejection. This translated to a odds ratio of rejection at 0.29 in a logistic regression model and a ROC area under curve of 0.89. Using an optimal cutoff based on the ROC analysis of 1.3, the biomarker had pretty strong predictive indices of sensitivity, specificity, positive and negative predictive values. These data were now validated in the internal validation cohort, which gave us a ROC area under curve of 0.92, and at the same cutoff used in the training set of 1.3, a sensitivity of 86%, specificity of 91, and very good positive and negative predictive values. Next, the diagnosis of de novo late rejection in the first post-transplant year after the assessment of the biomarker. In the training set, the biomarker performed well to be able to diagnose de novo late T-cell rejection with a ROC area under curve of 0.9. And again, the biomarker performed equally well in the internal validation cohort, giving us a ROC area under curve of 0.85 for the prediction of de novo late rejection with sufficiently strong sensitivity, specificity, positive and negative predictive values. Finally, looking at the subclinical rejection diagnosis in the first post-transplant year, the biomarker assessed at 3 months was able to predict a subclinical rejection in the first post-transplant year with a ROC area under curve of 0.86, again, with good sensitivities and specificity. And these data were validated in an internal validation cohort where we had a ROC area under curve of 0.92. So when combined the training and internal validation sets, and when we examine the frequency distribution of the IL-10 to TNF-alpha ratio in relation to the incidence of T-cell rejection, we were able to identify specific groups of patients. Number one, in patients who had a IL-10 to TNF-alpha ratio of less than 1.3, there was a significantly greater incidence of T-cell rejection ranging between 69% to 93%. In these groups of patients, when we examined the evolution of rejection within the first post-transplant year, we found that 60% of the high-risk patients had rejection diagnosed early on between 0 and 4 post-transplant months. Again, here, there was almost equal distribution of clinical and subclinical rejection episodes. Importantly, of those patients who had rejection early on, despite standard of care treatment, almost 50% of these patients continued to have recurrent / recalcitrant rejection when the biopsies were examined between 5 and 12 months post-transplantation. Another point to note, in those patients who did not have early rejection in the high-risk category, 74% of these patients had de novo late rejection, which is dominantly subclinical. Taken together, 58% of the high-risk category of patients had late T-cell rejection, either de novo or recurrent. In contrast, when we examine the low-risk category, which is the patients who had IL-10 to TNF-alpha ratio of more than 1.6, a handful of patients only in this group had evidence of rejection either early or late. Now, there is an intermediate risk group of a very small group of patients with ratios between 1.3 and 1.6. The risk of rejection in this category of patients is somewhat intermediate between the high risk and the low risk group. However, I should point you that this range of the IL-10 to TNF-alpha ratio, 1.3 to 1.6, is still well within the error margin of the bioassay performed using flow cytometry. So we clearly have a high-risk category of patients and a low-risk category of patients. Our biomarker was next examined in an independent external validation cohort of patients who were transplanted at Royal Free Hospital in London. These were 95 patients transplanted between 2011 and 2014. Immunosuppression comprised of besiliximab induction, followed by tacrolimus and mycophenolate maintenance immunosuppression. These patients underwent only 4 cause biopsies, and all patients were followed up for a 5-year period. Again, even in the external validation cohort, the biomarker performed extremely well for prediction of rejection, any rejection within the first post-transplant year, with a ROC area under curve of 0.92. In those patients who did not have any evidence of early clinical rejection, the biomarker again was able to identify patients with de novo late clinical rejection with ROC area under curve of 0.88, sensitivity of 69%, specificity of 92%, negative predictive value of 97, and somewhat lower positive predictive value of 48%. However, you need to note that these patients did not undergo protocol biopsies, and only clinical rejection episodes were taken into account for the assessment of biomarker in this cohort. To be able to examine the relationship between the biomarker and the interaction of various baseline clinical and demographic characteristics, we performed logistic regression, and this forest plot shows you, number one, the odds ratio for rejection based upon various clinical characteristics, and the ROC area under curves for the prediction of rejection based on, again, various clinical and demographic characteristics. To name a few, the biomarker was not affected by the recipient age, gender, ethnicity, donor source, HLA mismatches, and henceforth. And of all these factors, I'd want you to take a note at the influence of opportunistic viral infections, namely CMV and BK viruses, on the biomarker assessment. This bar chart here shows you that the IL-10 to TNF-alpha ratio within the T1B cells was not affected by the presence or absence of CMV or BK infections within the first post-transplant year. The only factor determining the cytokine ratio in our patient cohort was the rejection episodes, not the viral infections. In addition to the viral infections, the biomarker was not also influenced by the degree of non-adherence to the CNIs, measured by intra-patient variability of the CNI trough levels, as you can see in the forest plot. Next, looking at the biomarker and its association with the long-term clinical outcomes in our entire cohort. In both the UPMC cohort and the external validation cohort, high-risk patients defined by the biomarker have significantly worse overall graft survival at 5 years of follow-up. In a similar fashion, high-risk patients also had worse death-censored graft survival at 5 years and worse incidence of the composite endpoint of graft loss and impending graft loss at 5 years. Therefore, the biomarker is able to risk stratify patients for poor clinical outcomes. Importantly, when we examine the clinical outcomes based on the biomarker risk stratification in those patients who had particularly normal biopsies at 3 months, again, we found that the biomarker high-risk patients with normal biopsies at 3 months had significantly worse overall graft survival, death-censored graft survival, and higher incidence of composite endpoint, which includes graft loss and impending graft loss, again suggesting, independent of histology, that the biomarker is able to risk stratify patients for poor long-term clinical outcomes. To summarize this part of my talk, I've shown you with my initial data from UPMC that the current immunosuppressive strategy of treating rejection is failing high-risk patients. And based on our biomarker assessment, I'm able to show you that the T1B IL-10 to TNF-alpha ratio was tested and validated as a predictive biomarker for renal allograft rejection, and it also risk stratifies patients for premature graft loss. Next, we've looked at some mechanistic assays looking at the functional characteristics of the biomarker high-risk and low-risk patients. For this, initially, PBMCs from either high-risk or low-risk transplant patients at 3 months post-transplantation were either depleted of B cells or cultured in the absence of B cell depletion with anti-CD3 for 72 hours. B cell depletion was achieved with magnetic enrichment or magnetic depletion of the B cells. So the T cell cytokines were examined in the presence or absence of B cells. What we found was summarized in these bar graphs. First, let me explain to you what happens in the low risk category of patients, that is n equals to 4 per group. In the low risk patients, B cell depletion significantly increased interferon gamma and TNF alpha expression by the CD4 autologous cells, while there was a significant suppression of autologous CD4 IL-10 expression, suggesting that B cells have a regulatory function in low risk patients. However, when you examine the relationship between B cell depletion and T cell cytokines in the high-risk patients, we found that there was no influence of B cell depletion on T cell expression of interferon gamma or TNF alpha, whilst the expression of IL-10 was somewhat uncovered in the high-risk patients. These data suggest that there is a lack of regulatory activity in patients who are deemed high risk based on the biomarker assessment. So when the B cells were cultured along with an isotype control or with anti-TNF antibody ex vivo on anti-CD40 cell layers along with CpG for 24 hours, and we've examined the IL-10 to TNF alpha ratio in the presence or in the absence of anti-TNF, we found that anti-TNF significantly increases the IL-10 to TNF alpha ratio, not only in all the B cells, but also specifically in the T1B subset of the B lymphocytes as well. When the similar experiments were repeated to examine the expression of other pro-inflammatory cytokines by the B cells, including B cell IL-6, IL-12, and GM-CSF, we found that anti-TNF significantly suppresses B cell expression of IL-6, GM-CSF, and IL-12, not only in the total B cells, but also in T1B transitional B cells as well, suggesting that the pro-anti-inflammatory cytokine imbalance could be restored by the use of anti-TNF, at least in vitro setting. When such B cells, which were either treated with anti-TNF or untreated, are co-cultured with the T lymphocytes, we had 3 experimental conditions, wherein T cells are cultured alone, or in the presence of B cells, or B cells that are blocked with anti-TNF. And when the T cell cytokines were examined, we found that anti-TNF treated B cells significantly increased CD4 IL-10 expression, and at the same time suppressing CD4 TNF alpha expression. These in vitro data support the notion that anti-TNF not only increases the IL-10 to TNF alpha ratio, but also improves their in vitro BREG activity as well. Finally, when PBMCs were stimulated with recombinant human IL-2 and R848, which is a TLR7 agonist for 7 days in the presence of an isotype control or anti-TNF, we found that anti-TNF significantly suppresses the differentiation of B cells into plasmablasts on day 7 ex vivo. Interestingly, those plasmablasts which are proliferated express more IL-10 in the presence of anti-TNF in the cultures. When the cell culture supernatants were examined for the various immunoglobulin subclasses, we found that there was a selective suppression of IgG1 and IgG3, the complement fixing immunoglobulin subclasses. So to summarize this part of my talk, the in vitro studies that I've shown you so far show that anti-TNF restores the IL-10 to TNF alpha ratio and increases the in vitro BREG activity of these cells. And it also inhibits plasma cell differentiation and complement fixing antibody secretion. These studies provide a rationale for the use of anti-TNF to augment immunosuppression in high-risk transplant recipients and improve clinical outcomes. I think I'll stop here by thanking our group in Pittsburgh, the Rothstein lab group, and our collaborators in London and Leeds in the UK. And more importantly, I would like to stop by thanking all the patients who participated in these studies and our funding agencies. I'll stop my presentation here and I'll move forward with the question and answer session. Thank you so much.
Thank you, Aravind, for that lovely presentation. Before we get into the questions, I just want to say that the follow-up of your in vitro studies was very elegant, and definitely mechanism-wise it adds to what could be happening in these patients. So thank you so much for taking time to share that data with us. So as the questions are rolling in, I'll just start with the first question. And it says, if the IL-10 TNF ratio in T1 B cells is a marker of greater regulation of immune responses, are infections more common in patients with high levels of this ratio?
Now, what we found was that there was no significant differences between the high and the low ratio groups as far as the opportunistic viral infections that we routinely monitor, for example, CMV and BK viruses. But I cannot definitely say as far as the incidence of bacterial infections like urinary tract infections, which we tend to see pretty commonly in the first post-transplant year. That data I haven't completely analyzed, but that is something that can be easily assessed. Thank you for that question.
Thank you. Let me double check the next question. Well, I'll read it. Beautiful study which expands our understanding of alloimmunity. Given recent work of Weib and Nickerson, will you examine HLA applet mismatch, not HLA antigen mismatch, to determine if this is an upstream of your B cell phenotype? Importantly, combine molecular HLA mismatch with DSA to see if these routine clinical tests precede or add to your biomarker data.
I think this is a fantastic question. Of course, with the advances that are made in the HLA field, and especially with the use of HLA applet mismatches, there is a very good possibility that there could be an additive effect when both the applet mismatches and a biomarker like ours or anyone else's that have been marketed could be useful. So we are in the process of proposing a clinical trial using our biomarker, and the same question will be addressed, hopefully with our clinical trial or the clinical study moving forward.
All right, the next question asked, did you look at immune responses to vaccines, and were they lower in patients with high IL-10 TNF ratio?
And again, this is a very interesting mechanistic question that could easily be addressed moving forward, especially when we have biorepository samples and patients get routine vaccinations. Of course, with seasonal influenza vaccinations, and we all know that patients with advanced chronic kidney disease have variable levels of responses to vaccines. So such an assessment could easily be made. This is something that we've discussed in the past when I was presenting these data to various groups, but this is something that we haven't examined, but I think that this can be examined moving forward. I'm pretty sure Dr. Rothstein will have something to say on this topic.
Yeah, not a lot. I mean, obviously, transplant patients have lower responses to viruses in general, and whether or not we can detect a difference, I think we'd probably have to study a big cohort. But that data should all be available for us to look in. It may not be currently captured in our. I guess actually we probably have to do it prospectively, right? Because we'd have to not just. Right now, we're not routinely measuring not just, viral antiviral titers. So we'd have to build that in prospectively. But as we go forward with other studies, that's something we should look at.
So it's not a question that's listed, but what do you believe could be some adverse side effects of this potential anti-TNF therapy, or in what ways do you see that being applied?
So yes, it's a great question with clinical implications. Whoever asked this question. So let me take a step back and present to you a paper that's published maybe nearly 7 or 8 years ago. It's a German group looking at small bowel transplants. And these are small bowel transplant recipients. These are a handful of them, 8 or 9 patients who have any immunosuppression resistant rejection. They had loads of thymoglobulin that was given, the rejection was resistant. And these patients were offered anti-TNF as a rescue therapy for the rejection. And all the 9 patients in the rejection episodes completely resolved. And there was one reactivation of EBV, although there was no subsequent development of PTLD in that group. And there was no incidence of any significant adversities, for example, premature development of cancer or any other nasty infections. And moreover, if even if you take a further step back and look at the use of anti-TNF agents, these are not new agents. These are pretty comprehensively used in various other non-transplant settings. For example, inflammatory bowel disease, psoriasis, rheumatoid arthritis. And in general, whatever the marketed agent is, anti-TNF has been deemed to be sufficiently safe for use in clinical practice. Although in transplant recipients, there are ongoing NIH-sponsored clinical trials that I'm aware of, looking at the ability of anti-TNF agents used early on when used as a single dose to be able to limit ischemia perfusion injury. I'm not aware of the compiled final data from those studies, but at least looks like those studies are ongoing. So to sum up, I would argue that anti-TNF as an additive agent to enhance the B regulatory activity could be considered relatively safe and possibly effective. But again, the effective part of the question should only be addressed by a proper clinical trial.
Again, it's not standard of care to add in several doses of TNF blocking. I think it's Intercept in islet transplantation. That's offered right up front along with induction immunosuppression, et cetera, as opposed to in our setting, it would be delayed for several months. So we got the biomarker study results back at 3 months. But I mean, so again, added evidence at least short-term blockade. And then, I mean, that's the question. You can design a clinical trial however you want. The question is, how long would patients need to be on anti-TNF? What is a reasonable course? And at what point, would you stop? And would the biomarker change with treatment so it could be used to monitor exactly that? So these are all things that we don't know presently.
And to add to Dr. Rothstein's point, the German study that looked at the use of anti-TNF in all anti-rejection therapy resistant rejection, people got as many as 9 to 10 doses of anti-TNF.
They actually got 15 to 22 doses. It was protracted in that small bowel transplant study.
Dr. Martinez, you had a question?
Yeah, I had a few, but I just want to start with one, and then I think we have some more from the audience. I just wondered just what you thought mechanistically, what drives this early balance or sets this early balance of these B cell, the ratio, the IL-10 TNF ratio, and also is it sustained over time in the individuals that don't develop rejection?
So thanks for this question, Dr. Martinez. And one of our observations was this. So patients who have this extreme elevations of IL-10 to TNF alpha ratio, I think part of it could be driven by a repopulation of B cells following thymoglobulin induction, number one. However, patients also tend to have differentiation into high versus low IL-10 to TNF alpha expressors right from the word go, even prior to transplantation as well. So between time zero, this is the data that we haven't discussed in our publication here, but between time zero and when we re-examine the biomarker at 3 months, some patients tend to cross over from high to low risk versus low to high risk. This crossover is around the 20% mark. But in a remarkable 75% of the patients, the risk for heightened LO response or the B regulatory activity being in an imbalance seem to be predetermined. And if you were to re-examine the IL-10 to TNF alpha ratio, either in the high-risk group or in the low-risk group, and follow it longitudinally through the first post-transplant year, again, we found that patients tend to maintain their risk status through the first post-transplant year. But the one point I want to make, in addition to these observations, is this. Some of the immunosuppressive agents, for example, prednisone, has an effect on the B lymphocyte constitution. So it can significantly deplete the transitional B cells, and as such, the T1 transitional B cells as well. So use of steroids, for example, for the treatment of rejection, could have an influence on how these ratios are measured and how these B cell subsets are examined. But for all other practical purposes, when we examine the B cells or the subset cytokine ratios, they remain pretty stable through the first post-transplant year.
Thank you.
Great, thank you. Dr. Chong says, congratulations on the great work and observations. What is the percentage of patients that have the high risk versus low risk IL-10 TNF phenotype?
So so I can comment on this based on our observations in Pittsburgh and in London. So in Pittsburgh, we tend to transplant a lot of high immunological risk patients, and almost 44% of our patients tend to be in the high risk category, whereas about 46% of the patients tend to be in the low risk category. In London, for some reason, the distribution was slightly lower, wherein the high-risk category of patients only constituted about 20% of their patients. So it is variable, but from our observations in 2 centers, the range is anywhere between 20 to 44% for high risk.
I mean, you may have answered part of this question already. Were these ratios determined only post-transplant? And if so, can these ratios be affected by immunosuppression?
So, the first part as to where these ratios measured only post-transplant. For the purposes of this manuscript data presentation, we only presented the data on post-transplant examination of the cytokine ratios, but we also have data on
Aravind, let's only talk about what was published.
Sure. So we have the data for post-transplant assessment, number 1. And with regards to the effect of immunosuppression, in our stratified analysis, wherein we showed the forest plot, we looked at the effect of either thymoglobulin or besliximab usage, and they don't seem to have an influence on the cytokine ratio per se. And again, as I suggested to Dr. Martinez early on, some of the immunosuppressive agents, for example, steroids, have an effect on the constitution of the B cell compartment, and that may have some influence on these cytokine ratios as well.
Okay, thank you. The other question says, well, it's a comment first. Very elegant study, congratulations. Did you look at tissue, specifically kidney, expression of biomarker BREG and IL-10 TNF ratios?
We haven't for this study. That's a subject of an ongoing investigation in Pittsburgh. So we are looking at that.
Okay, thank you. Were patients with autoimmune diseases able to achieve good outcomes, or did they all develop rejection biomarker?
Haven't specifically looked at that question in our study, but that's a very great suggestion. It can be something that we can easily look at, because we have a sizable patient population, so we can look at the impact of the biomarker on the transplant outcomes in autoimmune patients, but we haven't looked at that data.
Great, thank you. As more questions are coming in, Dr. Martinez, did you want to ask more questions?
Sure. I just had another question, which was in those patients that were low risk in terms of their ratio, but then developed rejection. Was there anything that distinguished the rejection in that group from those that had the high risk phenotype?
So the numbers were so small, Dr. Martinez, that pretty much limited our ability to be able to assess the rejection category in the low-risk patients. We're talking about a handful of patients, namely 4 or 5 patients who had rejection. Of those, 1 patient had recurrent or recalcitrant rejection when we examined. So, but overall, to summarize, these patients in general responded well to their treatment, and there was a lot less incidence of either recalcitrant or de novo late rejection in those patients as well. But any further comment, I think it will be premature to be able to make comments on like a handful of patients.
Okay, thank you.
Some of this was already answered, but just to go through the question, with anti-TNF biologics having increased complications of TB and other infections, would you be worried about adding anti-TNF in the clinic in our patients that are immunosuppressed?
So again, the same argument about the use of anti-TNF in non-transplant settings where patients are on a multitude of immunosuppressive agents will answer this question. For example, you may want to take like the basic precautions while enhancing immunosuppression for any of our patients, including the anti-TNF agents as well. You may want to screen for TB and also for hepatitis B virus. So screen for the infections to start with, take all the basic precautions you may want to take while enhancing immunosuppression to any of our patients. Yes, the reactivation of TB is a concern with anti-TNF agents. And yeah, if the screening proves to be positive for tuberculosis, you may want to avoid these agents purely for that risk.
All right, so the next question we already kind of talked about a little bit, but the person wants to know, did you compare the ratio in patients pre and post? And you can answer that to whatever degree you want. And especially because it would be interesting to know if the patient is, especially if they're getting a second transplant.
So that's my K grant.
So that's just something we're starting to look at is even earlier pre-transplant versus post-transplant. So we can't really comment at this time.
Great, thank you. And one other question is, have you tried adding IL-10 rather than blocking TNF alpha? And would this change the outcomes?
We haven't done that experiment, but I can maybe answer this question in a slightly indirect fashion based on our previous studies. The paper we published in JASN in 2014, what we did was when we blocked IL-10, in transitional B cells, the transitional B cells lose their regulatory in vitro activity. And when you block TNF alpha, the memory and the naive B cells, which have a lot lower IL-10 to TNF alpha ratios, they enhance their in vitro B regulatory activity. I hope this somewhat answers your questions that the IL-10 and TNF alphas have or blocking or enhancing these cytokines will have like a yin-yang kind of a response as far as in vitro assays are concerned. But again, having said that, these are in vitro assays for whatever they're worth. It will just give you an insight as to how these cytokines can be manipulated. But what exactly happens in vivo in humans' body is beyond the scope of this investigation.
Okay. Dr. Martinez, may I ask you a question? If you like?
Yeah, I was just wondering if you've looked or if you care to comment on, so this study was in kidney, if you've looked in other organ transplants like livers or hearts for these cells and if you find the same thing.
So there is an ongoing study looking at the liver transplant patients we've just started and hopefully we should be able to come up with some data very soon.
But we are very interested. So if anyone has a biorepository of other transplants, or for that matter in autoimmune disease, we would be fascinated and happy to collaborate because it obviously remains a big question. A priori, I think that this should be generalizable, but obviously the proof will be in the pudding. So we're eager to address that question.
All right, the next questions ask, what is the percentage of patients with high versus low risk IL-10 TNF ratios? Is the ratio altered by immunosuppression, or is this ratio determined by patient genetics?
So again,
that was Anita's question that was reposed from that was already addressed, although I guess she's added some new points, so you can go ahead and address that.
So again, the first part, the high-risk patients range between 20 to 44% of our population based on observations in London and Pittsburgh. And the low-risk patients, almost 50% of the patients will be categorized as low-risk based on the biomarker. And then there is this indeterminate or intermediate risk group, which is a small proportion of patients, about maybe around 10-15% of the patients. Now, moving on to the next question about pre and post transplant assessment. Again, this is an ongoing investigation which we are going to embark on, and that includes Dr. Chang's question about the influence of genetics and the genetic influence of the cytokine ratio pre-transplant. So hopefully in a couple of years, I should be able to come back with those answers.
Yeah, so there's one other part of her question, which is an excellent question, about how these transitional B cells work. And I guess I'd like to take the opportunity to mention that we don't necessarily think it's just the transitional B cells that are working as regulatory B cells. They happen to have the highest ratio, and why they end up being a better biomarker is not certain, but obviously transitional B cells themselves are short-lived. And if you look at all IL-10 producers amongst B cells, these would be a minority of the B cells. So I believe that other B cell subsets also that express IL-10 and other suppressive molecules are likely to be regulatory. And then one can ask, why it is that transitional B cells, short-lived, end up being a good window into what's going to happen, and whether this is just the fulcrum of the teeter-totter, or these cells that are high IL-10 producers as transitional cells maintain that as they develop into mature B cells. That's unclear. So it's a great question, and one that we're curious about. But I don't think that this minority of IL-10 positive cells necessarily is doing the heavy lifting of all the regulatory activity within the whole B cell population.
Yeah, I think to add to Dr. Rothstein's point, I think in an immunity paper published by the Matsumoto group, Matsumoto et al., a couple of years ago, they have a small section examining human B cell subsets and their IL-10 expression. And what they found was that when the transitional B cells are in healthy volunteers, which have a lot more IL-10 expression as a population, when they're pushed into differentiation into plasma cells, the plasma cells tend to have more IL-10 expression, and those plasma cells tend to have much more suppressive capacity compared to the differentiation of already matured cells into the plasma cells. Again, these are in vitro experiments, but maybe just to add to what Dr. Rothstein said.
Right, and actually, we've also in a previous publication shown that if you take other subsets that have of B cells that may have a lower, they may have more TNF and less IL-10, like naive or mature, naive mature B cells or memory B cells. And if you add anti-TNF into the culture to cover up the TNF produced by the B cells, then you uncover the regulatory activity of those other B cell subsets. So I think, and again, that's in vitro, but the belief would be that other B cell subsets have regulatory activity. And certainly in mice, that appears to be true because we have broader markers where many of the B cells, for example, they wouldn't be transitional, they would be marginal zone or even follicular. We have direct evidence that follicular B cells in mice that express IL-10 and TIM1 are regulatory. So why different subsets of B cells express regulatory molecules and it is unclear. Well, let's put it this way. It's unclear whether different regulatory B cells or B cells belonging to different subsets have distinct activities or they all just regulate. And that's an ongoing area of investigation.
Great, thank you. We don't have any more questions unless the panel has any other questions to ask. All right, well, thank you, Aravind, and happy birthday again.
Thank you so much.
Thank you, Dr. Rothstein, also for your time, and Dr. Martinez. If there are any other questions that come up later, please feel free to email or send them to Brian Valeria. And again, thank you, and everybody have a great Memorial Day weekend.
Thank you, everyone.
Thanks, everybody.
Thank you.
Bye-bye.
Yes. AST would like to thank our panelists and attendees for today's session. Please remember to complete the evaluation survey and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about the AST community of transplant scientists, please visit myast.org/COPS or connect directly to the Community of Transplant Scientists COTS Hub. Thank you all again for today's session.